need DHT. Wouldn't you agree?
Oh yeah, I mean, you've just broken the internet there. We've got about 5 reaction videos brewing.
Oh my God, bro! Oh hell no, man! What the fuck, man? Get your ass on!
Hello everyone, and welcome back to yet another video. Today we're going to be looking at a video released by the hair chemist concerning Dutasteride. Now, this won't be a real reaction video as I've already watched the video before, but a lot of people have been asking me to formally address the claims that are made in this video. So I'm not going to play the entire video because, well, it's really just a back and forth between Dr. Paresis and the hair chemist, where the two essentially state, and to be very honest with you, they're overstating and exaggerating it, oral dutasteride and its risk profile. Primarily, I'm going to be focusing on the claims made by the hair chemist. Essentially, I find that the hair chemist tends to fearmonger dutasteride, and really this entire video is pretty silly. It's odd because he should know better considering he has some sort of advanced degree in pharmacology, if I'm understanding that correctly. I'll also be looking at some of the comments he responded to in this video in his video's comment section.
People will, take a DHT blocker, often under the false assumption that this is going to stop hair loss in its tracks. And unfortunately, this stems from, that Japanese study of 100 men where it was found after 10 years, they remained, in terms of their miniaturization, it remained on track, that they didn't lose ground. And this is just false in terms of its representation of reality. And people need to be very careful to not look at studies always as being almost biblical and absolutely representing reality, because the clinical setting can often yield a different data set compared to a study that had 100 men. And there's no point going into the different parameters and all of this, but what we do know is hair loss is a progressive condition. And
okay, so hair chemist finds that using 5-alpha reductase inhibitors like finasteride and dutasteride won't stop hair loss, and how this is a false assumption that people tend to make. He says this is a misconception that comes from the famous 10-year long-term Japanese study.
From, that Japanese study of 100 men where
by Akio Sato et al., titled, quote, Long-term 10-year efficacy of finasteride in 523 Japanese men with androgenetic alopecia, unquote. In this study, it was demonstrated that the sooner you start finasteride and the longer you stay on it, the more likely you are to slow down hair loss, if not reverse hair loss, or maintain your current state of hair. Researchers observed that after 10 years in this study, 91.5% of patients, being 487 out of the 532, showed an improvement in their hair condition. 99.1% of patients, being 527 out of the 532, showed either improvement or no progression in their condition. When it came to people who got worse, this would only apply to the remaining 0.9% of the study population, which translates to about 5 out of 532 patients. So this is really good news. But the hair chemist mentions that the clinical setting in the real world doesn't always match these research papers.
The clinical setting can often yield a different data set compared to a study that had 100 men.
And you know what? He's correct, but only to an extent. This one particular study, the 10-year long-term finasteride Japanese study to be exact, is a longitudinal observational study, meaning over a long period of time, researchers observe the interventions of a drug or a treatment and compare each subject to their baselines, so where they started out versus where they ended up at the end of the study. Now, there was no placebo control group in this study that wasn't taking finasteride for 10 years, so perhaps the hair chemist might infer that, the hair loss could have just stopped in all of these patients on their own, right? Maybe it wasn't the finasteride that was contributing to a vast majority of these subjects having a slower rate of hair loss, or having better hair, or just keeping their hair that they had when they first started out, right? Well, no. First of all, this study is part of a larger body of literature, many of which has studies that have long-term comparisons between placebo control groups that do not use the drug versus groups that either use the drug or variations of the drug like finasteride and dutasteride over long periods of time and at differing doses. We have 6-month trials, 1-year trials, 5-year trials. There's so much data that suggests that these things actually do work. The overwhelming body of evidence shows that people who have androgenetic alopecia can slow down their hair loss considerably with finasteride, and in many, they may halt their hair loss indefinitely and even regain some hair in the process. And it's not even just about improvement of hair counts. There are other factors like the existing hair itself might actually become thicker. Even more so on the fact, dutasteride accomplishes this as well at even better efficacies. In fact, the Georgetown Review did a systematic review and analyzed a large volume of studies that concerned finasteride, dutasteride, hair loss, and safety profile. They found that both finasteride and dutasteride to be effective at slowing down hair loss and, in some cases, even reversing it in men with androgenetic alopecia. This body of research includes randomized controlled trials, which are the gold standard for determining efficacy of a treatment. The findings from these studies collectively highlight that while individual results can vary, the general efficacy of these medications in managing hair loss is well supported by scientific evidence. So, Hair Chemist is correct to point out that the clinical setting doesn't always fully represent real-world outcomes. This is a valid consideration in medical literature research known as the external validity, and this refers to the extent in which the findings of a study can be generalized to a broader population, or some sort of general practice. But guys, we're not in the early days of hair loss research where we don't know the impact of finasteride and dutasteride. The vast amount of data at this point from various studies, including those with long-term durations and diverse populations, helps us to mitigate these concerns by providing comprehensive evidence that supports the effectiveness of these treatments in real-world settings. Moreover, the concern that these effects seen in clinical trials might not exactly translate to real-world scenarios doesn't negate the fact that, for a significant majority, these treatments do result in positive outcomes. It's also crucial to recognize that while no treatment works universally for everyone without any exceptions, finasteride and dutasteride offer a significant possibility of hair retention and regrowth for many individuals battling androgenetic alopecia. And I want you guys to keep this in mind because I keep saying this over and over again. For individuals specifically battling and only dealing with androgenetic alopecia, there are other forms of alopecia. We'll touch on that later on in the video, but yeah, just keep that in mind. So while it's wise to consider the limitations and variability of clinical research, we also have to acknowledge the overall consensus from extensive studies and systematic reviews which support the use of 5-alpha reductase inhibitors like finasteride and dutasteride for managing and potentially reversing hair loss in those dealing with that condition. But before we move on, I want to highlight this comment that the Hair Chemist responded to in his comment section to this specific video, which I thought was just kind of weird and absurd. The comment suggested that the Japanese study isn't applicable to Western men. Now, I'm going to assume they mean Caucasian white people when they say Western men, possibly Western European men, because what else could they possibly mean? Look, I'm just going to call it as I see it. If you guys want to take some umbrage towards that, I don't care. The comment also claimed that 5-alpha reductase is underexpressed in Japanese men, implying that results don't carry over to Europeans or Western populations. First of all, we have studies done on European populations, like the 10-year long-term finasteride study by Rossi et al. On Italians, which last time I checked, they're European. But although there are some Europeans who think that Italians aren't quote-unquote Europeans or whatever, but I'll leave that for you guys to kind of debate amongst yourselves. In any case, it's not like the findings are entirely exclusive to one ethnic group. And secondly, this is a very complex topic, and we shouldn't reduce it down to just 5-alpha reductase expression. For instance, we have 2 studies that suggest that androgen receptor gene polymorphisms are consistently associated with androgenetic alopecia across different populations. The first study, titled, quote, Androgen receptor gene polymorphisms and risk for androgenetic alopecia, a meta-analysis by Chua et al., identified a significant association between the androgen receptor gene STUI polymorphism and androgenetic alopecia, with some similar findings across different ethnicities, particularly in white populations. The second study, titled, quote, Analysis of Genetic Polymorphisms of Steroid 5-alpha-reductase type 1 and 2 genes in Korean men with androgenetic alopecia, unquote, by Ha et al., examined genetic polymorphisms in the gene responsible for the type 1 and type 2 5-alpha-reductase enzymes in Korean men and found no significant differences that would otherwise prevent generalization across populations. The point here is that there may be a set of traits that determine when and how someone will experience androgenetic alopecia, but there's no reason to believe that these genetic characteristics are completely different in function from one race to another. It's more like that these traits are simply less prevalent in certain populations, rather than them being absent or fundamentally different. For example, the study titled, quote, Characteristics of Androgenetic Alopecia in Asian by Woo-Soo Lee and Ha-Jin Lee. And this study highlights the prevalence of androgenetic alopecia and how it differs significantly across Asian populations compared to Europeans. Japanese men, for instance, are stated to develop androgenetic alopecia roughly a decade later than Europeans do on average. But here, there's no reason to believe that they would respond differently to medication. These hyper-responder examples of East Asians on medications like Finasteride and Dutasteride could be contributed to their hair follicles and the hair that they produce, giving a better aesthetic coverage than straight-haired Caucasians. Essentially, East Asians have very wide and thick hair follicles, and despite typically having a higher prevalence of single hair follicles, the hair shaft and width dynamics really do make up for it. Again, East Asians tend to have very wide and thick hair shafts, and something similar could be said for certain black African populations that have curly hair patterns, such that the curl pattern gives a greater surface area coverage. When we look more into this particular study, in some Asian populations, such as in Singapore or Thailand, the rates of androgenetic alopecia approach or even surpass those observed in European populations, indicating that androgenetic alopecia-related genetic traits are not absent but merely vary in frequency and manifestation depending on the population. And finally, another thing that I would like to bring up is that in some Asian populations, they tend to have extremely long anagen cycles, so it might be the case that the onset of androgenetic alopecia might visually manifest later, but the mechanism is nevertheless still occurring. Many people only notice their hair loss when they've lost around 50% density in a particular area, but we all know that this has been happening for some time. It's not like your hair follicles just decided to fall out one day, at least if you have the condition androgenetic alopecia. There are other conditions where your hair follicles really do just kind of fall out all at once, so we don't have to entertain that just yet though, but generally speaking, when it comes to androgenetic alopecia, it takes a couple of hair cycles for you to actually see the damage that's been occurring. And with androgenetic alopecia, gradually the anagen to telogen growth phase ratio shrinks over time. However, if you naturally start out with a longer anagen to telogen ratio, then you probably do have a bit of wiggle room of, cycles in terms of how long it'll take for you to actually see that particular hair loss. So taking all this into account, you have to put things into perspective, and you can't just say, well, oh, that study doesn't apply to everyone, or it can't apply to everyone, because that's done in Japanese men, and us Western men, it's different for us. We have it bad. Just calm down, all right? That's not the case. These drugs are going to work in human beings. There may be some varied response, but it's not that large to necessitate that all these studies are somehow fake, right? But Hair Chemist says that this is somehow a great point that this commenter made. Like, goodness, we're only at the 3-minute mark of, responding to Hair Chemist's video, the 3-minute, 20-second mark, and this response is entirely verbose that I'm doing, but it has to be done, because it's videos like this that are just, people just make them, and they don't entirely state the sources that they're using. And in fact, Hair Chemist in this video kind of says studies don't matter, right? So he just gets to talk out of his mouth along with Dr. Paresis, and it's just embarrassing, okay? And it misleads people, and it doesn't really do, an honest kind of account of the literature. But let's move on to the next aspect of the reaction.
Compared to a study that had 100 men. And there's no point going into the different parameters and all of this, but what we do know is hair loss is a progressive condition. And anyone who takes finasteride, or the last resort dutasteride, continues to lose their hair. Ask any doctor. I'm sure you've seen the same thing, and you'll agree.
For sure.
He manipulated you again? Why would he manipulate you? Why would he do that? Did you give in? No!
Look, I've already been talking a lot as it is, but I need to cut in here and say that this is just BS. Hair Chemist is trying to paint a doomeristic view of both finasteride and even dutasteride. He states that anyone, essentially stating everyone on treatment, will continue to lose hair while using finasteride. He even says, in a weird way, the quote-unquote last resort dutasteride will also continue to lose hair. So this guy is pretty much trying to get you, the audience, to accept that there isn't that much you can do, and that there's this sort of inevitability for people who have androgenetic alopecia to continue losing hair. But why even say that? Because are you really going to be losing hair at a significant rate compared to if you didn't take the treatment at all? That's the goal, to slow down hair loss. And if you're not having a good response on finasteride, you should go to dutasteride. But why even wait when you can just use dutasteride as it is and just to get that, immediate response to know that you're responding to the most efficacious treatment? So if he can get you to accept this, he will essentially make you think it's futile to even attempt to use dutasteride because presumably you would have the same outcome, right? Now, I could sit here and tell you about all the studies like Olsen et al. 2006, which I will later on go into, but this study shows the superiority of dutasteride between 0.5 milligram up to 2.5 milligram versus 5 milligram of finasteride and placebo. Also, I could even show you studies that show how dutasteride improves hair counts more than finasteride. I could also show you studies that show how, as scalp DHT is lowered, hair count is improved. There was even that one case report by Dr. Rodney Sinclair and Dr. Ann Boyapati titled, quote, Combination Therapy with Finasteride and Low-Dose Dutasteride in the Treatment of Androgenetic Alopecia, unquote, that showed how in a man losing hair after 4 years on finasteride, despite originally benefiting from the medication in the beginning, a singular dutasteride pill was added to his regimen alongside finasteride at 1 milligram daily. So they introduced one 0.5 milligram gel capsule dutasteride once a week, alongside 1 milligram finasteride daily. And this helped grow his hair back in the thinning areas. We have a body of clinical literature to systematic reviews, meta-analysis, placebo-controlled, multi-centered randomized clinical trials, observational studies, prospective and retrospective data, and even case reports that all show evidence of this stuff actually working, and also being pretty damn safe. But all of this seems to be ignored by the hair chemist. And his only excuse is that, well, clinical settings don't match reality. But you can't reject clinical studies, especially when you have such an ample amount of observational and, just this wealth of clinical knowledge in the medical literature that tells you pretty conclusively that this works. And if he's rejecting it and he's over-exaggerating the harms, quote-unquote, the quote-unquote risks of the drugs, and then at the same time, it appears as if he's trying to mitigate its efficacy. The hair chemist even erroneously attempts to say that doctors will agree with him. And to complete the ethos of his argument, he refers to Dr. Paresis, who he is also, co-hosting on with this particular podcast.
Finasteride, or the last resort dutasteride, continues to lose their hair. Ask any doctor. I'm sure you've seen the same thing, and you'll agree.
For sure.
And Dr. Paresis, this guy's a hair transplant doctor who essentially parrots the same thing that the hair chemist is saying himself. First of all, there's already clinical data and a full body of medical literature that shows how finasteride, and even better, dutasteride, can slow down hair loss in people that have androgenetic alopecia. I know, I sound like I'm repeating myself over and over again because I want to get to the point. I want you guys to understand this, and more so, I want you guys to see how maybe, I don't want to say dishonest, maybe he could be being dishonest, right? But how the hair chemist is trying to misrepresent things, right? So I keep clarifying people who have androgenetic alopecia, not to sound annoying, but rather to note that if you're losing your hair on something like finasteride, and especially if you're losing your hair still on something like dutasteride, the chances of you just having androgenetic alopecia and nothing autoimmune like a non-scarring alopecia condition like alopecia areata, or even worse yet, an autoimmune scarring condition like lichen planipilaris and its variants, it becomes higher. And if you haven't been listening already, I need you guys to listen right now because I'm going to be exposing something that shows a huge gap and a huge bias that exists in the medical literature, but not in the way that you think. And this could potentially be affecting you. So let's start from the top. Finasteride and dutasteride reduce scalp DHT to a significant extent to the point where the interactions between DHT and the androgen receptors of the hair follicle are greatly reduced. Olson et al. 2006 shows us that between 0.5 mg to 2.5 mg reduces scalp DHT by 50 to up to 80% respectively. Other studies show that dutasteride wipes out intrafollicular DHT by over 98%. It is possible for someone to be very, very, very sensitive to DHT, such that any residual amounts, however small it is in their scalp, could potentially make them bald. However, I think it's also equally as likely, if not more likely, that if you're losing hair on something like dutasteride, you should probably go get a scalp biopsy in order to rule out that you don't have an autoimmune hair loss condition or any other conditions that could be making your androgenetic alopecia worse. And this is why it's probably better to start out with dutasteride and get a scalp biopsy at the moment of hair loss in order to not waste time in the event finasteride doesn't work for you, because you may be a bit more sensitive to DHT, but also to establish that you don't have an autoimmune, fungal, or inflammatory condition of the scalp that could also cause hair loss too. You see, the issue with many studies concerning androgenetic alopecia and even autoimmune conditions is that sometimes with androgenetic alopecia studies, the subjects are usually not biopsy confirmed to have the condition. And sure, there are a lot of assessments that a doctor can make in the initial assessment of somebody's scalp, right? Androgenetic alopecia tends to take on certain patterns, and you can look at family history. You can look at the scalp to have an understanding by using a dermoscope. And you could, to some extent, say that a certain person has androgenetic alopecia. But a biopsy is a pretty conclusive way of establishing that there are no underlying conditions that may not be visible to the naked eye. And many of these studies just simply don't have a biopsy confirmation that the patient only has androgenetic alopecia and nothing else. Biopsy confirmation requires that a small portion of the scalp, very, very small, maybe 4 millimeters, is cut out and assessed in a laboratory to see if the scalp tissue has any signs of a particular condition. It is important to establish that those who may be getting worse while on finasteride and dutasteride are not getting worse because of some autoimmune condition or inflammatory issue. Because if that's the case, then simply using finasteride, or hell, even dutasteride, will not help, because it's only going to reduce DHT in the scalp, and DHT is mostly relevant to androgenetic alopecia. According to Kania et al. From the Stats Pearl article on lichen planipilaris called lichen planipilaris, cicatricial or scarring alopecia rates are not precisely known, but lichen planipilaris is reported as the most common primary scarring alopecia. But we have a major issue due to some odd industry standards that I wish hair chemists and even Dr. Paresis would rather focus on instead of fearmongering about dutasteride safety. Kania et al.'s literature review on lichen planipilaris points to a major bias that exists in the dermatology space, and this is the idea that autoimmune scarring alopecias like lichen planipilaris mainly impacts women aged 40 to 60. You need to ask a question here. Is lichen planipilaris really more common in postmenopausal women, or is there a bias in biopsy practices? You see, when a balding man walks into a clinic, it's often assumed that he has the typical androgenetic alopecia. For my observations, dermatologists might prescribe finasteride or dutasteride, recommend platelet-rich plasma or PRP treatment, which usually doesn't work, and perhaps order some blood work at the very most. A diagnosis of androgenetic alopecia is given, usually without a biopsy. In contrast, hair loss in women tends to raise alarm among physicians. Even if the hair loss is consistent with androgenetic alopecia, doctors will do more extensive tests to rule out conditions like polycystic ovarian syndrome or menopausal changes. Doctors are more likely to run tests, including biopsies, beyond the initial examination. This is more or less confirmed as a practice. The review titled, quote, Evaluation and Treatment of Male and Female Pattern Hair Loss, unquote, by Elise A. Olson et al., 2005, provides insights into the emerging practices of the early 2000s regarding when to use biopsies for determining the histopathological features of a person presenting with hair loss. The authors state that in men, biopsies are, quote, usually not necessary unless a female pattern of hair loss, diffuse hair loss, or scalp changes suggest of cicatricial alopecia confuse the diagnosis, unquote. This suggests that male patients often bypass the detailed diagnostic step of a biopsy unless their condition deviates from the typical male pattern baldness. In contrast, the review points out that biopsies in women are deemed, quote, sometimes necessary to exclude chronic telogen effluvium, diffuse alopecia areata, or cicatricial hair loss, unquote. So we can see here that this indicates a more cautious approach towards diagnosing hair loss in women. But this is really harmful in the space of hair loss research. This gender disparity in the use of biopsies raises important questions about the potential underdiagnosis of certain hair loss conditions in men. Conditions like lichen planipilaris, which can present in a pattern form similar to androgenetic alopecia norid patterns, might be overlooked. In fact, we have this demonstrated in the literature already. The paper titled, quote, Lichen planipilaris in androgenetic alopecia area, a pitfall for hair transplantations, unquote, mentions how lichen planipilaris can overlap and mimic seborrheic dermatitis. Maybe Dr. Paresis should be concerned here because considering how he's a hair transplant doctor himself, he ought to make sure that his patients don't have this condition, otherwise the hair transplants that he's doing, where he could be potentially transplanting hair follicles into areas that are afflicted with lichen planipilaris, would result in that hair transplant eventually failing. And this could also contribute to the hair transplant failure rate, where even in some people that continue to take finasteride or dutasteride, they may notice that their hair transplant fails over time. And this could also be due to them having a condition other than androgenetic alopecia, like lichen planipilaris, or alopecia areata. I know that Rob English tends to get a lot of bullshit in this area because he used to make some pretty questionable videos back in the day regarding hair loss and essentially overstating how scalp massages can reverse, hair loss. But there was a really good video, and we have to give credit to Rob English, where he interviewed one of his clients who had a condition called alopecia areata incognita. So if you guys haven't watched that video, I'll put that video in the description, but it's a fantastic video, but it kind of shows the point that I'm trying to make here, right? Maybe if you're not responding to finasteride, dutasteride, oral minoxidil, topical minoxidil, it could be you have another condition besides androgenetic alopecia, right? Now, moving on to the next study that we have here, by Dr. Jennifer Crenchey and Moses Alfaro, in their article titled, quote, Lichen planipilaris mimicking androgenetic alopecia, the importance of using a dermatoscope, unquote. And this paper shows exactly what the title implies. Lichen planipilaris can mimic androgenetic alopecia, so there has to be a bit more of an elaborated look, but in this particular paper they were talking about using a dermatoscope to magnify the scalp and hair follicles so they can look for signs like parafollicular inflammation, which could be indicative of lichen planopilaris. But in any case, it's essentially showing that, yes, you have to actually look and have a bit more of an investigation when it comes to looking at somebody's scalp, right? And the same findings are noted by Dr. Ralph Trueb and Martin Zinkernagel in the paper titled, quote, Fibrosing Alopecia in a Pattern Distribution, Patterned Lichen planopilaris or Androgenetic Alopecia with a Lichenoid Tissue Reaction Pattern, unquote. And pretty much, like I said, it's the same point. Lichen planopilaris and its variants, being frontal fibrosing alopecia, can potentially manifest in a Norwood-like androgenetic alopecia pattern. So if a dermatologist or a hair transplant doctor was just looking at the scalp and didn't want to do any further investigations and gave that person finasteride or dutasteride, they would continue losing hair. If they gave them a hair transplant, they would continue losing hair, because these people are dealing with issues outside of DHT. It's an autoimmune condition. And just to highlight how extreme this bias in the literature is, which would have been a better thing to point out here, Dr. Paresis and hair chemist, okay? This would have been more productive if you guys actually looked into something like this and talked about this rather than fear-mongering about dutasteride's efficacy and safety. Let's just look at a study titled, quote, Lichen planopilaris in Women, a retrospective review of 232 women seen at Mayo Clinic from 1992 to 2016, unquote, by Sidney C. Larkin et al. And this study notes that lichen planopilaris predominantly affects women with a mean age diagnosis of 59.8 years. Now, the inclusion of a large number of women who are biopsied underscores the diagnostic approach typically taken for female patients experiencing hair loss. The authors, however, specifically state that, quote, men were excluded from this study to more accurately determine the association of hormonal factors in lichen planopilaris pathogenesis, unquote. Whoa, this is odd. So this exclusion of men prevents us from knowing the possibilities of any potential histopathological differences that lichen planopilaris may present in males, or even hormonal factors that could possibly exist beyond DHT. Now, I'm particularly concerned about the study's population selection, which mostly skews towards postmenopausal or menopausal women. The study finds that these women who presented with lichen planopilaris also had other comorbid conditions like diabetes, skin cancer, nutritional deficiencies, and much more. So not having a more rigorous investigation leaves out a lot of people, including, as I've previously stated, women who may not be menopausal or postmenopausal, but have a slow progressing scarring alopecia condition like lichen planopilaris. I just think it's crazy because it's implied that they did have the data for men. It is a retrospective review, right? But they just kind of like left it out because of a sort of preconceived notion that this condition only affects women, which, you know, again, it's just a bad reasoning and bias that exists in the literature. But it gets even more serious than that, because as I mentioned, this study found that these women are comorbid with other conditions, right? Well, let's look at it this way. Autoimmune conditions, even something like an autoimmune hair loss, has studies that show if you have one autoimmune condition, you may already have another one, or at some point you will develop another condition, such that autoimmune conditions are co-occurring. We can refer to this study titled, quote, Incidence, Prevalence, and Co-occurrence of Autoimmune Disorders over Time, and by Age, Sex, and Socioeconomic Status, a population-based cohort of 22 million individuals in the UK, unquote, by epidemiologist Dr. Natalie Conrad et al., published in 2023, and it highlights that autoimmune diseases, again, like I said before, are co-occurring. So, I guess, sorry for the spoiler. And just to highlight how weird the lichen planopilaris studies are and how the data just seems so skewed and kind of warped by this selection bias, we're going to look at a study published in September of 2022 titled, quote, Prevalence of lichen planopilaris in the United States, unquote, which was published in the Journal of American Dermatology International by Dr. Tejas P. Joshi et al. This cross-sectional study aimed to estimate the prevalence of lichen planopilaris using data from the All of Us research program out of 327 654,000 participants, only 142 had lichen planipilaris, representing a prevalence of, get ready for this, 0.043%. The study found that 91.6% of lichen planipilaris patients were female, with the highest prevalence among white participants, and an average age of diagnosis being 62.4 years. So I have a question for the people that did this research, and just anyone in this field. How many of these lichen planipilaris cases were biopsy confirmed? How many of the androgenetic alopecia cases were confirmed with biopsy? If diagnoses were based on visual assessment without biopsy confirmation, the prevalence in the data may be biased, particularly regarding gender. The study seems to support a preconceived notion that lichen planipilaris mainly affects postmenopausal women. And again, if you're only checking postmenopausal women when they present with these issues, then you're only going to have them recorded in the data, right? Because the biopsy data that would confirm lichen planipilaris, you're only using that for them. So it's showing the selection bias here in real time. And it may even be the case that some of the androgenetic alopecia cases could also have overlapping histopathological features that are similar to lichen planipilaris, or even other autoimmune conditions. If biopsies aren't being done on everyone in this dataset, it could very well be the case that lichen planipilaris is underreported. And this isn't even me just saying this. One of the world's leading dermatologists, Dr. Jeffrey Donovan, even holds this sentiment. On the matter, he states this regarding lichen planipilaris. He says, quote, "One needs to take into account the patient's entire story. If a physician just biopsies every patient that comes into the office, I can guarantee one will make a whole lot more diagnoses of lichen planipilaris than truly are present. I'm a big believer in this, even though lichen planipilaris is underdiagnosed in the world." Unquote. So with all of this in mind, there's a clear selection bias in the data. Men aren't biopsied as frequently as postmenopausal women. Additionally, biopsies might be underutilized in women with slow-progressing hair loss conditions like a gradual progression of lichen planipilaris that destroys hair follicles over years. These women might be excluded from biopsy data for a considerable amount of time. And to put a cherry on top, I too will make an ethos appeal like the hair chemist did when he was trying to refer to Dr. Paresis. I will be referring to the podcast that I did with Dr. William Rassman, the inventor of the FUE hair transplant procedure, along with being one of the co-founders of the Amplifica Holdings biotech startup company. And we did this interview on my podcast, Hair Stacks, if you guys are curious. During our conversation, Dr. Rassman mentioned that some of his colleagues at the Bernstein Medical Center for Hair Restoration make it a standard practice to biopsy anyone seeking a transplant. This is done to rule out potential causes of hair loss outside of androgenetic alopecia. Dr. Rassman explained that through this more rigorous analysis, both he in his own practice as well as Dr. Shaver and the other staff at the Bernstein Medical Center have identified comorbid conditions of hair loss, such as androgenetic alopecia and lichen planipilaris. So I'm actually going to play that part of the interview right over here, and then I'll come back. Looks like is a diffuse unpatterned hair loss. There are many conditions like hyperprolactinemia, hypothyroidism, and even some forms of areata, like alopecia areata incognita, that can manifest a DUPA-like condition, aside from androgenetic alopecia. That being said, have you ever recommended scalp biopsies in your practice when it comes to more atypical patterns of hair loss?
Yes, Dr. Robert Bernstein and Dr. Christine Shaver in New York. Dr. Shaver she's a dermatologist, and she had a particular interest in something called lichen planipilaris, which is another disease of the scalp that causes hair loss. There are a series of diseases of the scalp that cause hair loss, and you don't want to do surgery, hair transplant on people that have fronting fibrosing alopecia or lichen planopilaris or a variety of these other scarring alopecias. So she has made a habit of starting to biopsy young men in two places when she has even a suspicion that there might be some underlying disease, even though it doesn't show very well. And she has found an enormous number of patients have lichen planopilaris, which means that these people, if they had a hair transplant, will fail. Eventually, sooner or later, will lose their hair. So when we look at, I look at my career now 34 years in the hair transplant business, and I used to see every once in a while a patient would come in 10 years out, 7 years out. I even remember somebody 3 years out that came to me and he had a beautiful head of hair after the surgery. And then all of a sudden the hair started to fall out. And I always used to think of the hair around the side and back as permanent. It never went away. But at that time, I didn't understand that these people probably had lichen planopilaris and had this autoimmune disease in the scalp. And it was just inactive. And then as they got older, it became active. We find these diseases far more common in women than men. And for that reason, because they're so common in women, the doctors haven't thought of this as a male disease. And yet it is a male disease. And Dr. Shaver is basically writing this up now for publication. So I think that this is an important observation. And so to answer the question, you make bad diagnosis.
I see.
I think if I'm suspicious of something, I'll biopsy it.
From what I see on websites like Reddit, people often suspect that they may not only have androgenic alopecia. And because not everyone is getting a biopsy, it could be the case that issues like lichen planopilaris and other conditions are often overlooked.
The problem in the hair transplant industry, and I don't mean to be too accusatory, but there are many doctors that enter this business that just learn how to do FUE and they don't learn dermatology of the scalp. And if they don't learn dermatology of the scalp and the diseases of the scalp, then they're going to not recognize these diseases, and then they're going to transplant these people as they develop balding, and then they're going to fail maybe 3 or 5 years later.
Yeah.
And when they failed in my hands down the road, and this, by the way, in my practice, the numbers that would fail were about 3% that would fail out there in 5, 10, 15 years later. But I'm sure that those 3% were lichen planopilaris, and a diagnosis that was never made. And by the way, nobody knew about it then. It wasn't like I was just a bad doctor. Nobody had talked about it. It was never considered a disease in men. And sure as hell it is.
So guys, I know I just talked a lot. Believe me, I can feel my mouth getting extremely dry right now, so maybe my voice will sound different when I come back and record this later. But these are some pretty important points, and it speaks to what Hair Chemist says. Sure, clinical settings aren't one-to-one with the real world, because there are so many factors to take into account.
The clinical setting can often yield a different data set compared to a study that had 100 men.
However, let's actually point out a blind spot rather than concern trolling and saying some BS about people losing their hair and how it's inevitable no matter what they may do, okay? You're not actually showing what's going on, you're just kind of obfuscating things. This perspective will make people not inquire deeply about the causes of their hair loss and even their health, as we know that if you have lichen planopilaris or alopecia areata, these are autoimmune conditions. And as we've stated before, autoimmune conditions seem to be co-occurring. So let's say you have lichen planopilaris and you go get checked and you have Crohn's disease, right? That could also be a possibility. This is why you need to inquire about these things and not have such a huge blind spot. And honestly, I think I'm one of the few people in this space and even in broader academia that's pointing out this blind spot. And, you know, Dr. Paresis and the Hair Chemist, you guys are welcome to join myself and even more so the esteemed Dr. Jeff Donovan in kind of calling this out, right? And joining Dr. Rassman as well. But they're not doing this, right? Dr. Paresis and the Hair Chemist, they don't seem to be interested in pointing something out like this. It's either they don't know or they, for whatever reason, aren't doing it. I'm going to say that they don't know, just to be charitable here. But that is not an excuse for them to just say all this blatant, BS about finasteride and dutasteride, especially when it comes to their efficacy and their safety. So I would say that starting with dutasteride and not finasteride is the meta here. Not only that, but getting a scalp biopsy to learn more about your hair loss makes sense in finding the right treatment for you if you suspect that you don't only have androgenetic alopecia. When you get a scalp biopsy, they take a small bit of tissue out of your scalp, and yes, in doing so, that tissue, that area, you lose some hair follicles, maybe about 40 or 50 hairs, and that area is replaced with scar tissue as the area kind of heals back. But I want to ask you this question before you start freaking out. Don't you think it's useful to sacrifice 40 or 50 hairs to learn about the potential fate of maybe 100,000 or 50,000 hairs on your scalp? Really? Put that into perspective. And if you can't find a dermatologist who's willing to look at this data, I'm sorry, but you're just going to have to find a good one that is willing to accommodate you and actually look at this data. Because really, this is a huge blind spot that not a lot of people are pointing out. It's your health at the end of the day. Learn how to advocate for your health, especially when you go to a doctor.
Years that really, after about 5 years, this is where you can see the progression. And it only gets worse and gains momentum. That of course, it's not saying that after 5 years, you just lose your hair. That's not it. It's just after 5 years, typically, is when people see from therapy that, it's not as great as it was. And the drugs work in the same way. But the problem is now there's a movement towards the last resort, which is dutasteride. And this is a very problematic movement among young men. And they're trying to attain a silver bullet, that they think that by taking dutasteride and getting their DHT down to the bare minimum, that hair loss will be stopped. It will go away. And of course, that is not what you want to do, because it will still be ongoing, because it's not all about DHT. We know that it's a primary culprit, but we don't fully understand hair loss. We don't understand the other mechanisms that are involved in it.
Okay, so the hair chemist really emphasizes and over-exaggerates the inevitability of hair loss. Now guys, look, in the previous section I already stated what you should do if you notice hair loss that is getting worse on finasteride, and that would be first to switch to dutasteride and get a damn scalp biopsy. And if you're already on dutasteride, then you definitely need to get that scalp biopsy right now. Because the data on continued hair loss on these drugs would suggest that you're either very, 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 very sensitive to DHT, or perhaps even more likely, you have another condition that is making your androgenetic alopecia worse, whether that's lichen planopilaris, whether that's some sort of seborrheic dermatitis, or if it's some sort of diffuse alopecia areata, or something like folliculitis decalvans, or even tinea capitis, also known as ringworm. And sorry for the abrupt voice change. I had to record this part again because there was a corruption in the audio and I just woke up, so. But yeah, let's get back to the other audio. A scalp biopsy, or even something called a KOH test or KOH wet test, these things can further what you might have. That being said, slowing down hair loss and offsetting it by anywhere from a decade to half a decade is good news, and that's on finasteride. We know that with the 5-year long-term dutasteride study from South Korea, that dutasteride tends to even work better. So it isn't uncommon for doctors to switch patients to dutasteride or have dutasteride be the starting therapy for men with androgenetic alopecia. Finally, I think it's likely that the hair chemist is referring to the 10-year long-term finasteride study on Italian men by Dr. Rossi et al. Because he claims that 5 years is the peaking effect while you're on these medications. Now, the data is a bit more complex from how he is presenting it. So let's look at it ourselves. At the end of the 10-year follow-up of the study, 24 patients, being 21%, showed further improvement, while 74 patients, being 65%, maintained their hair improvement. So they pretty much hit the peaking effect, but they didn't get any worse. So this means that a total of 98 patients, or 86%, experienced positive outcomes, whereas 15 patients, being 14%, showed worsened hair conditions. These 14% of patients showed a worsened hair condition compared to earlier assessments, which means their condition was worse than their baseline at the start of the study. They did not respond positively to treatment, or their hair condition deteriorated over the 10-year period. So maybe these patients could have been better on Dutasteride. Also, another important part about this study was that there were some people who, after 5 years, they still showed continuous improvement up to 10 years while being on the drug Finasteride. But there were also some people who, after 5 years, experienced some minor decline in hair counts. However, they were still well above baseline. So what does that mean? That means at year 10 or at the end of the study, they were way better than they would have been at year 0 or the beginning of the study. And you can kind of make similar comparisons to the 10-year long-term Japanese study using Finasteride, where they pretty much had the same conclusions, right? If you look at the graph on that particular study, you can see that there were times, where the hair count between the groups kind of fluctuated, but generally speaking, the trend was upward. And with factors of how early you took the drug in terms of your normal progression and when compared to baseline, they were just better off, right? So that does conclusively state that you're going to get benefits if you have androgenetic alopecia when you use Finasteride, and even better, Dutasteride. But again, I do have to question how many of these people that didn't respond well to Finasteride actually only had androgenetic alopecia and nothing else, like lichen planopilaris, maybe seborrheic dermatitis, or some form of chronic folliculitis decalvans. How many of these people in this study were biopsied at various points to only confirm whether or not they just had androgenetic alopecia? But I think that's something to entertain seriously, considering how the biopsies and the statistics concerning them seem to be very biased, such that we're not getting a good idea when it comes to how many people are truly affected by this condition, because we're so focused on postmenopausal women due to notions that, well, women can't have hair loss, or it's very unusual for them to have hair loss. So when a woman comes to our clinic with hair loss, we tend to have a preference of biopsying her because it could be indicative of another condition that's more serious. Because, and of course, we already know this, they weren't biopsied, it wasn't stated in the study at all. But if they were biopsied, maybe it could have told us that the people that don't respond well are people that also have adjacent or just other conditions that affect their hair follicles. It was hair chemists that did say that these studies often don't reflect the real-world clinical setting, and that's true. That sort of external validity that I talked about earlier in one of the previous segments. So taking that into consideration, hopefully Dr. Paresis does scalp biopsies of his hair transplant clients, or maybe he can recommend his clients to dermatologists that understand pathologies of the skin, and hopefully hair chemists can start actually looking at studies and not just, dismissing them all around due to that sort of external validity, whatever. Because maybe the external validity kind of becomes a fallacy at some point.
Reality, because the clinical setting can often yield a different data set compared to a study that had 100 men. And there's no point going into the different parameters and all of this, but what we do know is hair loss is a progressive condition. And
he manipulated you again? Why would he manipulate you? Why would he do that? Did you give in? No!
Anyway, let's move on to the next segment of this very, very long response or reaction video, whatever you want to call it. If you got this far, comment in the comment section below. Green dog. GREENDOG. Like a literal green dog. All right, let's just jump into it.
Logically, you're taking a drug that it's used for benign prostate hyperplasia clinical dosages, where people who have benign prostate hyperplasia on Finasteride at clinical dosages for benign prostate hyperplasia aren't responding to, so they go to Dutasteride. Now, Finasteride is FDA approved for hair loss at 1 mg. So for Dutasteride, it is really for people with prostate issues, who have enlarged prostates, who are older gentlemen. where finasteride isn't enough. And this is at much higher dosages than what is approved for hair loss. So they go to dutasteride. And there comes with that far increased risk of side effects. And DHT is a hormone that is useful. What would your thoughts be?
Okay, so I'm guessing that the hair chemist just doesn't know what he's talking about here, or maybe he's intentionally misrepresenting things. First off, dutasteride is approved in several countries like South Korea and Japan for the treatment of both benign prostatic hyperplasia and androgenetic alopecia. Next, we actually have a phase 3 clinical trial study for dutasteride use in androgenetic alopecia, and this is that Olsen et al. 2006 paper that I keep talking about, and its title is, quote, "The Importance of Dual 5-Alpha Reductase Inhibition in the Treatment of Male Pattern Hair Loss. Results of a Randomized Placebo-Controlled Study of Dutasteride versus Finasteride," unquote. This was conducted by GlaxoSmithKline, also known as GSK, and it not only demonstrated that dutasteride at 0.5 milligram was more effective than finasteride at 5 milligram in combating hair loss from androgenetic alopecia, but 2.5 milligram dutasteride was even more effective than 0.5 milligram dutasteride and 5 milligram finasteride separately. This study is very well done considering how it was randomized, multi-centered, double-blind, and placebo-controlled. And it had about 416 men between the ages of 21 to 45 years of age broken into various dose groups of dutasteride against 5 milligram finasteride and placebo. And in this study, you can see things like the change in hair counts and also scalp DHT suppression, and how the two things are inversely related, right? So as scalp DHT goes down, hair counts generally improve and the hair typically thickens and gets better. Now, there are a few reasons why dutasteride didn't make it to market. The first being that at the time, Merck was starting to deal with some lawsuits concerning finasteride and its side effects. And it wasn't a secret that Merck, along with other drugs like Vioxx, they were experiencing issues, especially in the early 2000s, where there were a lot of frivolous lawsuits that got these drugs taken off of the market. So if I'm GSK and I'm seeing that our sister drug, finasteride from Merck, is dealing with this kind of issue for androgenetic alopecia cases, it's not really encouraging for me to take dutasteride to market, so that's something to consider. The first Propecia lawsuit was filed on February 2nd, 2011. By this time, Merck was getting dragged through the mud in the United States of America and even facing issues years before in the Swedish market, mainly due to over-exaggerated side effect claims. Next, finasteride itself wasn't that profitable of a drug for Merck, and there's no reason for GSK to assume that dutasteride would have been more profitable than finasteride, or even one of the most profitable drugs in its portfolio. Putting things into perspective, between 1990 and 2010, Merck & Co. developed several blockbuster drugs that significantly contributed to its revenue and profitability as a company. Propecia, also known as finasteride, approved by the FDA in December 1997 for the treatment of male pattern baldness, achieved peak annual sales of $447 million in 2010 and 2011. While Propecia finasteride was a successful product, its sales were modest compared to Merck's other leading drugs during that time frame. This included Zocor, a cholesterol-lowering medication, introduced in 1992, Singulair, approved in 1998 for asthma treatment and generating approximately $47.9 billion in lifetime sales, Fosamax, launched in 1995 for osteoporosis, and Cozar, approved in 1995 for hypertension. Vioxx, introduced in 1999 as an arthritis pain reliever, also contributed significantly until its withdrawal from the market in 2004 due to safety concerns. Propecia's position in Merck's portfolio further diminished after its patent expired in June 2013, allowing for the entry of generic finasteride and reducing its market share. So for GSK, there was no real benefit to market dutasteride in the United States for androgenetic alopecia, especially because GSK's dutasteride patent from that starting point of where Merck's litigations began in 2011 was set to expire in 4 years on November 2015. So that should kind of paint the picture of what GSK was dealing with. So when Hair Chemist says, well, this drug is only supposed to be used for benign prostatic hyperplasia. That's not true at all. And he's very much so misrepresenting the facts on dutasteride. And it's just weird. And I know he has seen these studies because it's been brought to his attention many times on other videos, so I'm not sure why he chooses to ignore that, but I guess it's at his own convenience, right?
Is a hormone that is useful. What would your thoughts be on that, Dr. Paresis?
I totally agree. I love the point you highlighted about the difference between what we see in research and what we see in real life. My clinical experience, and Dr. Bloxham would agree with me, and Dr. Feller as well, they've been seeing hair loss patients for over 30 years, over 10,000 patients, and a lot of them have been taking finasteride and dutasteride. The incidence of side effects with dutasteride is more than finasteride, that's for sure. And that does mainly revolve around sexual side effects. Libido is complex. It's got a psychological component and a biological component. And, you know, some people say, oh, if you're thinking about having libido problems, then you'll give yourself libido problems. But in my experience, and from what I've seen from patients taking dutasteride, which, as you said, really blows the DHT out of the water, really reduces your DHT by a large amount, the number of side effects that patients are getting with dutasteride is just more, and they are affecting their libido. Now that does suggest that DHT contributes to libido. You know, it's not very complicated. You know, 1 + 1 is 2. If you take dutasteride, which reduces your DHT, and you get libido issues, then DHT contributes to libido. That's for sure. Yeah. And yes, there are. Hormone. Yeah, go ahead. What were you going to say?
It's a sex hormone, and it is goes towards performance.
Exactly. You know,
so here's where I get into the safety and side effects of dutasteride. Look, guys, I'm very verbose at this point with my response, but let me start off by saying that the same reasons that hair chemist and Dr. Paresis state that dutasteride is dangerous would certainly apply for finasteride. I'll refer you to the Georgetown Review, which looks at various studies, a lot of studies by the way, and concludes that finasteride and dutasteride have similar side effect profiles and side effect rates. Really, side effect rates only increase when you go beyond the 0.5 milligram dutasteride and you hit the 2.5 milligram dutasteride mark, as seen in the Olson et al. Paper from 2006. But even then, we know that with discontinuation and when the drug fully leaves your system, side effects generally subside. We also know that with continued use, side effects in most people subside. So I'm not sure why we have to ignore these facts in the literature, simply because these two Muppets, I guess you can say, Dr. Paresis and the hair chemist, find it to be convenient to kind of gaslight girl boss or whatever, or, you know, let me be serious, but, you know, to essentially fearmonger about dutasteride. And it isn't just one study. It's thousands of studies, each done by independent organizations and universities that tend to come with the same conclusion. And DHT is very useless after puberty, and this has been established in many studies. It seems to cause mostly more problems than having any sort of benefit. In fact, testosterone itself is more useful and doesn't have as many drawbacks as DHT. But I'll give a little bit of an olive branch and be honest here, right? The only issue here is that by inhibiting DHT, the free testosterone that would have turned into DHT stays as free testosterone, thus increasing your free testosterone levels. In some people, some of this free testosterone aromatizes or transforms into estrogens, which can potentially cause side effects due to a shifting in hormonal profile. So it is the androgen to estrogen ratio that can cause these issues, especially with libido. If your estrogen levels are too low or too high, it can cause side effects, and I'll put some studies on the screen and hopefully in the description so you guys can kind of, you know, look at this yourself, right? I'm not going to delve into another study again, but I just want to kind of, you know, bring this point up. But this is why blood work is kind of important to see where your baseline is so you could potentially titrate and introduce the drug to your system slowly. If you happen to be someone on the extreme ends of the testosterone and estradiol reference ranges. Also, libido is very much a mental thing, and this can't be excluded by any means. So maybe you just don't find your partner all that sexy at all. Or maybe you're broke, right? Maybe you're having a tough time at work, or maybe you spend too much time on internet forums where you get a bunch of dudes that sit around and tell horror stories, and they fester their psychological issues towards each other. Yeah, that's the nocebo effect in real time, and its effects are very well documented for finasteride and dutasteride. So give me a break on this part, seriously. I don't know why this guy's fearmongering along with Dr. Paresis. You guys should know better.
I wouldn't notice hair coming out, and of course it does, but the point is you don't perceive, this change. So it did wonders. So I got a bit greedy and came across the study of Rodney Sinclair and decided to incorporate dutasteride into my routine. Now, I could not find a hair restoration doctor who would willingly prescribe me this drug, so I had to go down the GP route. And we tried it on once a week, like yourself. And I was pretty shocked because I don't have the psychological predisposition where I'm saying, oh my God, I'm going to have side effects on this drug. I'm terrified. And then there's issues downstairs. What happened to me was I started to feel a sensation of pain, testicular pain, numbness. And then eventually my pelvic floor had this feeling of numbness as well. It was quite bizarre. And I have to connect it to the dutasteride because there was no other change in my medicine routine. And this wasn't from, a muscle injury or working out. I don't do that. And it was clearly from the drug. Whatever pathway it's going, I don't know. But I noticed it. And I've had experience with side effects on orminoxidil, so I know they are transient usually, but not always. As you know yourself, they're not always. And you can develop side effects where you need to get off of that drug. But I persisted on this. And the side effects, those side effects in terms of numbness and that went away. But it really didn't sit well with me.
All right, guys, I'm not sure what hair chemist and his friend Dr. Paresis is on here. So he seems to have got more side effects, and I'm talking about hair chemist here, on dutasteride once a week compared to finasteride daily, such that he was taking dutasteride at 0.5 milligram once weekly, and that gave him more side effects than finasteride 1 milligram daily. So I actually asked him in the comment section if he could explain how this is possible, and how if this isn't some sort of nocebo effect. Hair chemist has a degree in pharmacology, so he should be able to explain the pharmacokinetics and pharmacodynamics and how this is even possible. But he doesn't really do that. In fact, I have people from my Discord server, and they've also published this on the Trustless community website, that have actually gone through the literature and made these Python programs where you can, simulate different doses and different protocols of dutasteride, and you can see the pharmacokinetics and pharmacodynamics of the drug, such that we can examine scalp DHT levels as well as serum DHT levels, both in respects to the serum concentration of dutasteride. In fact, the graphs that I'm going to be showing on the screen is the pharmacokinetics and the pharmacodynamics of 0.1 milligram dutasteride daily versus 0.5 milligram dutasteride weekly. So you can kind of see the differences there in the graph, where it seems that 0.5 milligram dutasteride weekly are going to get, within that weekly time span, you're going to get some fluctuations of DHT levels, which probably isn't good for you, right? You want to kind of suppress it at an even kind of rate, where with 0.1 milligram dutasteride daily, it seems the suppression is very consistent and steady. So I'm just going to put these two graphs up so you guys can kind of compare it for yourself. But my point is, these are, people from my Discord server, Jonathan and Fuzzy, I think even a guy named, I'll call him Dutasteride Drake, and I think another person named Ranger, right? These guys, they all went into the literature. They found these studies, I think the Giessen-Klog study that showed the pharmacokinetics and pharmacodynamic modeling. They found these studies and they were able to kind of elucidate the matter on their own, right? Hopefully I can have these guys on a podcast one day. But the point that I'm trying to make here is, hair chemist, you studied pharmacology. You should be able to articulate these things. You shouldn't throw studies away and just speak from my feelings or my personal experience or whatever like that. You should be able to, take your anecdotes and kind of, use the literature to back up what you're saying. But he doesn't do that. And I find that to be very irresponsible, in what he's doing. It just doesn't look right. So presumably this would mean that 0.5 milligram dutasteride once a week lowers more DHT than finasteride 1 milligram a day. And is this even substantiated? You're trying to sell me on whether or not you didn't have a nocebo effect, right? And maybe he did have a nocebo effect. Maybe he didn't. But I would appreciate it if he could articulate himself a bit better. Look, I'm nearing the end of this video here, and I think the takeaway point here is that this guy, hair chemist, just makes a bunch of claims in this video without substantiating anything. What I find to be especially weird, and some people even pointed this out in the comment section, is that he promotes the use of oral minoxidil on his channel and claims that it's safer than oral dutasteride. First of all, the best study that we have is a retrospective study on 1,404 people, which for whatever reason excludes people who didn't take the low doses of oral minoxidil for longer than 3 months. The reason why this is important is because we have case reports that show that people who typically get side effects typically get it very early into treatment or very early into increasing doses of oral minoxidil. So maybe they were good at 0.5 milligram of oral minoxidil for, let's say, a year, but then they decide to, go up to 2 milligram or 5 milligram, right? In the early stages of them titrating up to that, dose, they could get side effects. Not only that, but this study that I'm referring to being the, quote, safety of low-dose oral minoxidil for hair loss, a multi-center study of 1,404 patients, unquote, literally says that side effects are dose-independent and idiosyncratic to the patient's genetics. Meaning, they didn't find that there was a specific dose range that caused people to get side effects. People were getting side effects at various doses. And it could be the fact that it's due to their genetic characteristics. Now, there's a factor here that the side effects from minoxidil, oral minoxidil, is actually from minoxidil sulfate, right? And I'll put a study here that shows that. But I think it's conceivable if we were to analyze people who had high sulforotransferase enzymatic activity, and this is the enzyme that transforms minoxidil into minoxidil sulfate, and minoxidil sulfate is what elicits its effects on the blood vessels and even very severe side effects like pericardial effusion, and even hair growth at the same time. But if we were to examine the sulforotransferase enzymatic activity, I think in that sense, it's conceivable that side effects are dose-dependent on minoxidil sulforotransferase or minoxidil sulfate production. So you can have somebody that, let's say, takes 5 milligram oral minoxidil, but their genetic characteristics can only turn 5 milligram oral minoxidil into around maybe 0.2 milligram minoxidil sulfate, where in some other individual, maybe they take 1 milligram oral minoxidil and all of that gets converted into minoxidil sulfate. So over there, you can kind of see that at some point they have different side effect profiles. So maybe conceivably you could say that it is indirectly related or dose dependent to minoxidil, but probably it could be more dose dependent to minoxidil sulfate. But this is the issue, right? We don't have studies that adequately look at this, and these studies are still coming out, but Hair Chemist is promoting something that has even less evidence of its long-term safety, by the way, right? We don't know, if there's any sort of issues with long-term safety when it comes to using low-dose oral minoxidil, if it damages the blood vessels or anything like that. But we have a better understanding of long-term use of 5-alpha reductase inhibitors like finasteride and dutasteride. than we do with low-dose oral minoxidil. We do understand what minoxidil at higher doses does beyond 5 milligrams, so at maybe 10 milligram to 40 milligram being the therapeutic doses, but that only indicates to us bad things, right? It tends to have a lot of bad and nasty side effects at those dose ranges. So we don't know if that also exists at low dose ranges in a long-term kind of sense. So that's it for this video. Don't listen to these two guys, Dr. Paresis and hair chemist, more so maybe hair chemist. I'll be a bit more charitable to Dr. Paresis because he is a good transplant doctor, but I do think he's, at least in this video, he's not really showing his knowledge of the literature and very much overstating the side effects and risks of oral dutasteride. So, I mean, I would say proceed with caution when you're listening to these guys, and look at the literature yourself, and don't let somebody make a blanket claim like, oh, the clinical setting doesn't match the real world. Yes, the external validity thing is true. That is true, right? But you need to look at the overwhelming body of evidence in a particular space of medical literature to kind of understand, well, does this thing work? Does it have demonstrations of it actually working? And if so, how generalizable are its, findings to different populations and even just the real world, right? So I've been talking a lot. My mouth's kind of numb, and it is getting late. I'm recording this on December 1st of 2024. And yeah, see you guys later on the next video, so peace out.